My name is Dr. John Bertagnolli. I've been doing this series for the last few years here at AROC. I'll be the moderator for today, also be the first lecturer. Just a little bit about myself. I'm an associate professor of family medicine at Rowan SOM. I got my degree at UMD&J SOM back in the day. And I'm also board certified in family medicine, and I have a CAQ in hospice and palliative care. I'm also a physician at Samaritan Hospice, one of the team docs there. That's been for the past year. I've been doing hospice work for about the last 10 years. I was also a recipient of the AOA Mentor of the Year in 2010. They like to put that in there because the AOA likes that. It's a student-run award, so I'm very happy to have received that and privileged. So today, I guess I have a captive audience because everyone here needs the 2 credits for the state. That's okay. We'll do some of the things that I've done previously. It may be somewhat of a rerun, but we'll also have some fun at the end. I have a few things we'll talk about. How many here do palliative or hospice care? Raise your hand. Great. Team docs? Work for hospice? Great. Okay. How many people do house calls? Wow, it's growing. Okay. I'm also a director of the new Rowan House Call Initiative. We started that last year. So we take some students and residents, and now the residents need to be trained in house calls, ACGME guidelines. So that should be interesting for a lot of programs. But today we're going to talk about palliative care, end-of-life decisions. So let's talk about what Governor Christie did back in 2011. He signed legislation that enables the patients to indicate their preferences regarding life-sustaining treatment. That's what's called POST, the Practitioner Orders for Life-Sustaining Treatments. And that has to be signed by the patient's practitioner or an APN and the patient or surrogate. So it really just requires 2 signatures. And it provides instructions for the healthcare personnel to follow for a range of life-prolonging interventions. There is a copy of the POST form out front. Hopefully everyone got a copy of it. We can talk about it when we go further through the slides. This becomes part of the patient's medical records, and it follows them wherever they go. They can carry it with them. They can bring it home. They can bring it to a different ALF. They can bring it to a different nursing home. They can bring it to rehab. They can bring it to another hospital. They can bring it to the zoo if they want. They can bring it wherever they want. The form is portable. So, it was unveiled at a news conference in 2013, and now many people are using it. So, once it's completed, like I said, it's transportable, and it's really meant for the seriously ill or those who are medically frail with limited expectancies regardless of their age. Can you do a pulse form? If you want a pulse form for yourself, absolutely you can do a pulse form. You don't have to be frail. None of us know when we're going to die anyway, so we could all be at the end of our life at any time. So sure, you can put a pulse form on file if you want. There's nothing that says you can't. The pulse was developed in response to the seriously ill patients receiving medical treatments that were not consistent with their wishes or goals. And the goal of the pulse is to provide a framework for the do's and the don'ts a patient may request. So the guidelines. It includes the goals of care for the patient, their preferences regarding CPR or attempts at CPR, their preferences regarding the use of intubation and mechanical ventilation for respiratory failure, their preferences for the use of artificial nutrition and hydration, and any other preferences of medical interventions they desire or not desire. It's not mandated by law, it's voluntary. But once it's signed, it becomes a legal document and should be followed in good faith. If not, you're liable for civil or criminal retributions. So just remember that. If somebody has a pulse form signed and you don't do what they want on the pulse form, you can be sued, you can be fined by the state. I haven't heard of any cases of anyone that this has come to court yet, but I don't want to be the first one. It does not replace the advance directive. It complements it. It complements it. It doesn't replace it. It never expires. But you can update it. You can change your mind. Some people change their mind. They want resuscitation. A lot of times early on in hospice, they want resuscitation. Then they realize they change their mind, so they become what we call DNR, do not resuscitate. You can still fill out that form that people have in their bedrooms, they have on the chart in the hospital, they have on the chart in the nursing home or the assisted living facility. That form still exists, but the pulse form complements that. What are the differences between an advance directive and New Jersey Pulse? Advance directive is not a medical order. The pulse form is. The advance directive is for all adults. The New Jersey Pulse form is for people of any age. Advance directive is for future care. New Jersey Pulse is for current care, but can be for future care also. The advance directive needs quite a few signatures, the individual, 2 witnesses, and a notary. New Jersey Pulse just needs a physician or the APN and the individual or the surrogate, the POA, or the guardian, whichever it may be. It's a lot simpler. So let's look at it. Goals of care. You can write in there whatever the patient wants you to write in, or they can write it in, or the family, the POA can write it in. It may be as simple as maintaining my ADLs. Maybe as simple as just keep me comfortable. There's a lot of different things. Whatever the goals of the patient are or the POA, that's what goes in that spot. Medical interventions. You can see full treatment. That's a little blurry up there. I can't see that. So that means they want everything. Limited treatment. They want to be transferred to the hospital for medical interventions, or transferred to the hospital only if comfort needs cannot be met in the current location. Symptom treatment only. That means they don't want to be hospitalized. Let me go to artificial administered fluids and nutrition. No artificial nutrition, long-term artificial nutrition, or defined trial period. So there's choices there. The form's fairly simple. It's a checklist. The only thing you have to write in, goals of the care and your signature. Cardiopulmonary resuscitation. Attempt resuscitation. Do not attempt resuscitation, die a natural death. Airway management, intubation and artificial ventilation as needed. Do not intubate. Use O2 manual. Do not intubate. That's the big thing here. And then it comes to the signatures. It's fairly simple, but once this is signed, it's a legal document. You have to remember that. There's the directions. They're usually on the back. It's a green form. You can use a photocopy and fill it out. That is also legal. It doesn't matter. They just made the green form easier to find on the chart in the hospital. But gee whiz, we're paperless now, aren't we? I had my aunt in the hospital 2 months ago, and I asked for a pulse form. You know how long it took them to find a pulse form? First they had to figure out what it was, and then I had to direct them to where I thought it may be in the hospital. So even though I do this every year, still people aren't on the same page. Hospitals aren't on the same page. Now we're paperless, it makes it more difficult. So let's look at some of the frequently asked questions for PULSed. Does the PULSE form replace a traditional advance directive? No. As I stated before, it complements it. If someone has a PULSE form and an advance directive that conflict, which one takes precedence? The PULSed, huh? How many say PULSed? How many say advance directive? How many say the paperwork that was filled out last? There's the trick. Whichever one is more recent, that's the one that you go by. We got that? Whatever one is more recent, that's the one that we're supposed to honor.
Is that the statute, or that's just a general good idea?
Even though it's a legal document, if your advance directive has something different, that takes precedent. Because it is updated, it's newer. You may not have a chance to redo the post, or vice versa. So whatever one that's legal, whatever one it has been done most frequently, that's the one that takes precedent. Who should discuss and complete the pulse form with the patients? That would be us, or the nurse practitioner. It's fairly simple. Can the pulse form be completed for patients who can no longer communicate their treatment wishes? How many say no? How many say yes? A physician or an APN can complete the pulse form based on a legally recognized surrogate. So if they have a POA or a guardian, they can complete the form for the patient. They sign it and we sign it. So they're doing it on behalf of the patient. They're the patient advocate. They're the patient surrogate. Can a patient's pulse form be changed? Absolutely. You can update it whenever you want, whenever the patient wants. Maybe the patient becomes comatose and the POA, and maybe the family has a meeting and the POA decides that they want the pulse form changed. Absolutely, they can change it. Who should a patient's pulse form be reviewed? When should a patient's pulse form be reviewed? When the patient's transferred from one medical center to the next? When there's a significant change in their health? Or if they have different treatment preferences. Like I said, maybe they changed their mind. They wanted to be resuscitated and they changed their mind 6 months later. They don't want to be resuscitated. They wanted artificial nutrition and hydration before, now they don't. Or vice versa. People can change their minds. You just change the form. Are fax copies and photocopies valid? Must green paper be used? Fax copies and photocopies are valid. Green paper is preferred and should be used to distinguish the form from other forms, but we're paperless now, so I don't know how this is going to work because we scan it in and it doesn't get scanned in color, at least not in my office. And the patient's, it becomes part of the medical record. The form will be honored in any color as long as it contains the appropriate signatures. Any color doesn't matter. Orange, red, white, doesn't matter as long as the appropriate signatures are there. So I pulled this out because these are pretty much the most commonly asked questions of the physicians last year. And I figured we'd answer some of them before we just turned it loose to everybody raising their hand and asking the same questions. So I think I've covered pretty much the pulse form here. So just remember, it's a legal document. It should have the patient's wishes and goals. We should honor the patient's wishes and goals. Be a patient advocate. Put yourself in the patient's place. Would you want the doctor making the decision and not honoring your goals, not honoring your needs? No, I wouldn't. So like I said, and I tell my students, put yourself in the patient's place. Okay, so we beat the pulse form to death here. Let's see what we can do next. The art of admission. Hospice is still an art. I want to make you comfortable with using several evaluation scales and be better able to understand hospice admission criteria. Now, I've used a lot of the same slides, but I'm going to just pick a couple and tweak them so you know what's happened with ICD-10. Yes, hospice still has to adhere to ICD-10 also. But they fine-tuned it for us. They made it a lot more difficult. So, general guidelines for hospice admission. There's a progression of disease, and we know there's a progression of disease because there are patients, and we see them failing. And we have documented it in our charts that there's functional impairment. They have multiple ER visits. They've been in and out of the hospital, multiple home visits. The phone calls every week that there's another problem. As long as that's documented, then we can look at them for hospice admission. We use Karnofsky's or Palliative Performance Scales. They have to be less than 50%. That's a guideline for us. And they should be dependent on 3 out of 6 ADLs and a reduced BMI. The big thing is you have to ask yourself the question, do you think this patient will die in less than 6 months? That's the question. You have to use your clinical expertise. And if you're unsure, then get a hospice consult. If they're not ready for hospice, we're not going to take them on because we have to meet CMS guidelines. And if we don't meet the guidelines, the hospice doesn't get paid. So, maybe they need palliative care, not hospice yet. So look at that. Do you think they have less than 6 months to live? And we'll look at some of the guidelines that we use to determine that. The KPS, Karnofsky's Performance Scale. Let's scroll down and look to 50%. Requires considerable assistance and frequent medical care. Well, that could be a lot of people. That could be a lot of people. The Palliative Performance Scale is a little more definitive. The decline of functionality, they're not doing anything. They may be starting to not take their medicine, decrease oral intake. They're still mentally with it. They're not comatose at this point, but they're failing. 40%, they're disabled, require special care and assistance. So you see, we use this functionality scale. It's not a guessing game for us. We do have performance scales that we use to give us some guidance. So the most commonly referred hospice diagnosis is Alzheimer's disease. We're going to talk about that. AIDS, ALS, cancer, renal disease. Can't use end-stage renal disease. Well, we can. We have to tweak it with other things. Adult failure to thrive is gone. Can't use that any longer. Cardiac disease, we have to be very specific with cardiac disease. And I'm going to give you an ID in a few minutes. Liver disease, pulmonary disease, and stroke. They're the biggies. These criteria are suggested guidelines. They're not exact or exclusive criteria. Cancer, diagnosis confirmed by pathology or radiology. We do not need a biopsy. We do not need a piece of tissue to put them on hospice. If they have evidence of metastasis or recurrence, that's good for hospice. It's bad for the patient. It's a seesaw. What's good for hospice is bad for the patient. What's good for the patient is bad for hospice. So sometimes when we put people on hospice, they get better because we're getting more help into their home or more help wherever they are, wherever they're living. We're doing symptom management, symptom treatment. And sometimes the symptom treatment makes people better. Some people come off hospice. They graduate hospice. Oops, we were wrong. That's a good time to be wrong when somebody comes off of hospice. It's not frequent, but it happens. And it's okay. They can come back on hospice for the same diagnosis or a different diagnosis. If they have Medicare, you have hospice benefits for life, no matter what the issue is. So just because they came off doesn't mean they can't come back on. So weight loss, low BMI, ascites, shortness of breath, behavioral changes, that's cancer. Pulmonary disease, progression of the disease that we have documented on the chart. The frequent flyer in the ER, frequent infections, frequent physician visits. Shortness of breath at rest. they're poorly responsive to the bronchodilators, or they can't tolerate the bronchodilators any longer. We have people come on with pulmonary disease that are on no pulmonary medications, and my students say, how can that be? They're coming on for pulmonary disease. Well, their disease is so severe that the risks outweigh the benefits of the medication, so they're off the medication. Weight loss, O2 sat less than 88%, on supplemental O2. Fatigue, cyanosis, dyspnea. That's pulmonary disease. Cardiac disease, New York Heart Association Class 4, symptoms at rest. Now, this has become a little more complicated. We used to use CHF. Can't use CHF anymore. You have to be more definitive. Systolic CHF. That's if their ejection fraction is less than 20%. Diastolic CHF. Doesn't matter what their ejection fraction is. But that's still not enough. We have to say whether it's acute or chronic. Acute or chronic, or acute on chronic. So no longer can we use just CHF. We have to really fine-tune the diagnosis. How many hospice docs out there are having fun with that? Yeah, it gets kicked back. We have to finely tune these diagnoses. So, if you want to send a referral to hospice with just CHF, that's fine. But send us a little more information, and maybe we can tweak it out from their last hospitalization to see where they fit, so we can put the patient on hospice and give them some care. Alzheimer's disease. There's another one. Can't use just Alzheimer's disease or dementia any longer. But I want to go through the FAST 7, the FAST scale first, to see where they have to be for us to entertain an admission to hospice. Now, we like comorbidities. Comorbidities are great for hospice. Contractures, malnutrition, adult failure to thrive, we can throw that in with this as a comorbidity or a secondary condition. Sepsis, aspiration pneumonia, pressure ulcers. And here's the functional assessment scale that we use. Let's look at 6. Occasionally or more frequently over the past weeks, improperly putting on their clothes, needing assistance or queuing to eat, unable to bathe properly, inability to handle mechanics of toileting, incontinent. That's pretty bad. But that's not enough to be put on hospice. Just not enough at this point. We have to go to 7. Their ability to speak is limited to approximately or less than or equal to 6 intelligible different words in the course of an average day. Then we go to B, where it's a single intelligible word. So we may ask the patient, how are you doing today? Yes. Did you see your family yesterday? Yes. That's appropriate. What'd you have to eat for lunch? Yes. So we get the idea. There's a decrease in functionality. When we have a 7 scale, then we look at it and we try to figure out where they fit. And to keep them on, when we do the recertification, we have to show a functional decline. So the patient needs to be failing and going from maybe a 7A to a 7C or a 7C to a D when we do the recertification. If they're not failing, they have to come off hospice. That's the tough part. Liver disease. Abnormal labs, obviously. Somebody with a high ammonia level coming out of the hospital, ascites, hepatic encephalopathy, progressive malnutrition, sarcopenia, muscle wasting, cachexia, Hep B, hepatocellular carcinoma. Sometimes these liver patients crash and burn quickly. Others go on for years. End-stage renal disease, we need a creatinine above 8. That's fairly mandatory for admission for end-stage renal disease. Can we have a patient come on hospice for, let's go back to dementia. Yeah, we have to use senile degeneration of the brain or Alzheimer's disease, And Alzheimer's disease has to be early onset or late onset, with or without behavioral changes. Can we have a patient with late onset Alzheimer's disease with behavioral changes come on hospice on dialysis? How many say yes? How many say no? Oh, come on, guys. One way or the other? No. Yes, they can. Hospice now allows you to put people on that are on dialysis as long as that's not their primary diagnosis. Like I said, there's an art to this. Stroke. A PPS less than 40%. We like a little tighter. We like them to be more debilitated because stroke patients, a lot of them will last for years. They will live longer. So if they're unable to maintain hydration or caloric intake, they're refusing their meds, they're not eating, they have dysphagia, frequent infections, skin breakdown, pressure ulcers, coma, and then the family puts the PEG tube in. That's the tough part for us. We get patients that have PEG tubes or JG tubes. And they want to keep them going. Well, that's fine if that's what they want to do, but they usually aspirate. That's one of the major reasons we don't like PEG tubes put in these people and Alzheimer's patients, because they aspirate. ALS, rapid progression of the disease, increased shortness of breath, limited prognosis, impaired mobility, speech, aspiration pneumonia, sepsis. You see in the comorbidities, they stack up. The more comorbidities, again, better for hospice. AIDS, this is fairly hard. Steadfast, you need a CD4 count of less than 25 cells per microliter or a viral load greater than 100,000. And you need to be off your viral medications, your antivirals. Decrease in the Kornofsky scale, obviously, and again, the comorbidities, muscle wasting, cachexia, sarcopenia, encephalopathy, infections, edema, sarcoma, renal failure. Protein calorie malnutrition, this is a stretch, but we do use it sometimes. The serum prealbumin less than 15, that's a big thing that we like to have. When that hits, then we try to get a second comorbidity in there or a secondary diagnosis to help boost this. Let's do a couple cases, and then after the cases we're going to have some fun, and we may start the next lecture a little earlier. I want to give the next lecture a little bit more time. So a 95-year-old female is homebound, lives alone. Her family lives out of state. She hasn't seen her family doc in several months. She's been in and out of the hospital with recurrent UTIs and sepsis. She's lost more than 10% of her total body weight, now weighs 82 pounds. She's independent and does not need assistance with her ADLs. She has no comorbidities. Can we admit her to hospice? Yeah, right. You can admit her and you won't get paid. There you go. But realistically, no. She's not ready. So let's tweak it. Same patient, needs assistance with 4 over 6 in her ADLs, has several comorbidities. She's hypertensive, CAD, diabetes, Parkinson's, dementia. Now can we admit her? Yeah. Yeah. And you know what? We'll admit her and she'll probably do better. And it's 6 months when she comes up for a recert. We're going to see that she's better and we can't find anything to keep her on. And then unfortunately what happens, they'll take them off hospice. 2 weeks later we get a phone call, they're back on. Because they're failing again, because they lost that care. They lost the aide that's coming in 5 days a week and helping for 2 hours, bathing, dressing, cooking, doing laundry. They lost that RN that's coming out once a week to check on them. Some people go to the hospital and revoke, they come back out the next day, we put them right back on. There's no time limit. Okay, let's try another one. 78-year-old male has been living in an ALF for the past 5 years since his family was unable to care for him due to his dementia. He presents to the ER post-falling while being transferred from his bed to the wheelchair. Sound familiar? Yeah. He's had multiple falls during the past year and has recently become non-ambulatory due to a recent hip fracture. His speech is unintelligible and he cannot smile. He also has upper extremity contractures and a stage 3 ulcer and a 10-pound weight loss during the past 4 months. Does he meet CMS hospice criteria? Yes, we can admit him and we can get paid for it. 86-year-old female moves into an ALF. You cover and she transfers to your care. You're on call. She transfers you. Hi, I'm new. And you review the history. She has multiple recurrent heart failure the past year. She also has angina with occasionally relief with sublingual nitro. She's on maximum cardiac meds, including diuretics and vasodilators. Her EF is 40%. She's hypotensive, +3 edema. She has a DNR in place and wishes a DNH. She also asks you to take her off many of her medications. Do you think she'll expire in 6 months or less? Pretty good shot. Pretty good chance. And if she lives longer, oops, we were wrong. It's a good time to be wrong. And I try to teach the students when they're going to start their residency, that these are one of the questions the patients are going to ask. How long does grandmom live? How long she got to live? We are great prognosticators. She's fine. Take her home. She's got another 2 years. And then 2 days later, she's back in the ER, comatose. She had a stroke, she had a heart attack, or she's dead. Why does that happen? Because we don't want to talk to the families about this stuff. It takes time. And time is money. And a lot of people, we weren't trained in this. When I went to school, we weren't trained in how to talk to people about end of life. It's easier just to go in a room and say, yeah, grandmom's going to be fine, just take her home. We'll see her back in the office next month. That's easy. You know what? Grandmom's not doing so well right now. I think, she has less than 6 months to live. In fact, when I look at her, I think she may have about 6 weeks to live. Now what happens? Floodgates open, everybody's asking questions, and you're tied up for the next hour. All right? That's draining. That takes a lot out of the doctor. And again, a lot of us weren't trained in that, on how to do that. It's easier to say, take her home, she'll be fine. That's a disservice to the patient. And if you don't want to do it, get a consult. Get a palliative care or hospice consult. We're more than happy to do this. They're my references for this presentation today. I also do something a little bit more with palliative care. I travel to a third world country every year. In fact, I'm getting an email from one of my students as we look at this. I'm getting ready to leave for 2 weeks on the 16th, which is Easter Sunday. We go to Kingston, Jamaica, and we work in the slums in 4 shelters that house about 100 people in each shelter. They're all physically or mentally disabled. We go to 2 orphanages. One has 85 children, the other one has 40. They're also physically or mentally disabled. And this one student says, my passport is going to expire in July. Do I need a new one? I'm like, well, you better get over and get it now. I'm like, last minute. So, and they travel a lot, so I guess they really weren't looking. So, I want to show you some pictures from last year, just to have some fun here, because all we do down there is palliative care. There's nothing we're doing to save lives. We're just keeping people going. We're treating symptoms. And I take about a half a dozen students with me. I have a pediatric resident. She's a 3rd-year resident. It'll be her 3rd trip coming. My wife's a neurologist. She also goes. She spends her whole days in the orphanage doing neuro rounds with the students. I spend my time doing general care and wound care with the students. And I see some of my former students here who have gone. I see some physicians who have gone with me before. Dr. Donna Furbo here, she's gone with me several years. And it's just it's a great time. It's a great thing that the students get to see. Third world medicine without medications. That's pretty much what it is. Oh, there's the bus. So we have some happy campers there. We're getting ready to go. We travel into the inner city in Kingston. It's very well patrolled by a SWAT team in full gear. We stay in a group. We don't get out and wander off. There's one of the kids. A lot of asthma there. My second job is a drug smuggler, and I take in whatever I can, including nebulizers, a lot of albuterol, seizure medications. The students actually get to see what a mortar and pestle looks like and use it. They'll open up some dilantin capsules and grind it up and give the slurry to the kids who have seizures. There's a lot of torch syndromes down there, cerebral palsy, muscular dystrophy. As one of my students, who's here today, former student, says, Dr. B, there's stuff down here that doesn't even have a name yet. And that's pretty much like it is. There's one of the kids. It's one of the volunteers. We feed them, we dress them, we bathe them. We have a little, we do a little bit other than medicine. I take other people with me, lay people. And I have 19 people going this year. It's my 19th trip. I won't ask you for money to donate. Some of you have donated, which is great. It's my wife. I think she's got jelly beans there. I'm just banging on a drum all day when I'm down there, not doing anything. Having some fun. On a break. The young lady who's standing next to me just graduated from PEDS, her PEDS residency, and she wants to do PEDS Palliative. There is the third year PEDS resident. She'll be joining me again this year. A lot of spasticity down there. That's Bob. Bob's a bright kid. But in Jamaica, if you're incontinent of urine, you can't go to school. So, Bob's at the orphanage. Bob pretty much directs the place. He tells people what to do. Bright kid. That's Elaine. She's in family medicine now as a resident. That's her husband. He's in ER over at Kennedy Hospital. He's feeding one of the residents there. It's Mr. Redder. He's also a registered nurse. Oh, we're getting ready for the food line. That's an interesting thing. Where we go is run by an organization called Missionaries of the Poor. It was started 35 years ago by a priest. His name is Father Ho Lung. He's Chinese, born in Jamaica, raised Buddhist, and converted to Catholicism. Very worldly man. Food line, that's all grain in those bags. So really all we're doing is palliative care. We're just trying to take care of these people. So they open it up to the public, and there's 3 different types of grains in there. You cannot use a clear bag because they don't want anyone knowing that they're getting a handout. Right, Elizabeth? Okay. So, here we go. Now you have to watch because some of them will change their clothes and get back in line. And all we do is laugh and we give them another bag. There's the grains. There's different types of grains that we pack up. The lady with the blue thing on her head, I don't know what you call it, she's notorious. What? She's notorious for coming back in line. She'll take that off. She'll put a different color on. She's a character. And I've seen her every year for the last 5 years. So you get to recognize people. Okay, what do we have here? Something frozen. Chicken livers. Hi, this is one of my students who was going into surgery. She was loving this. There was blood all over the place. So we're giving out frozen packages of chicken livers. Some people want the gizzards, some people want the feet. Well, we found out in these bags that were donated were all frozen chicken parts. Some of them were in the bottom and people came back to get them. Oh, there's Elaine. We had to worry about Zika last time we were there. So we have to worry about CHIKV, Zika, and dengue. So I bought these tents that fit right on the bed. It's great, except they open at the end of the bed because they didn't have the side zippers when I ordered them. I used it one night, and that's about it. My third-year peds resident uses it every night, even though she fell out of bed one night and couldn't get out of the tent. And we all stood there and laughed for a while. It was a wonderful thing. She called me. She wants another tent this year, so I told her I'd bring it for her. That buccal mucosa tumor has been decompressed in the United States a couple times. They won't do it anymore. It's pretty much past beyond repair. That's Jason, and he's had some seizure activity last year. He's on medication now for seizures, Donna, just to give you an update, and Liz. Here's one of the facilities. They're all behind 18-foot concrete walls with barbed wire and razor wire on top to keep the elements outside from coming in. These people live in these facilities until they die. I've seen people go from the orphanage to the adult facility. I've been there long enough, been going long enough to see people who have passed away. It's Jason being fed. He has a hard time feeding himself anymore. The brothers who work there, they're there. It's amazing the work they do every day. They made one room, they call it their ICU. They put their sickest patients in there at Face Center, the one facility. And once they hit the ICU, they're pretty much near death. So the students actually get to see, a lot of them, their first death. Their first patient that has passed away on them while they're taking care of them. So I do a lot of talking at night with the students to decompress. Come to find out, students like Red Stripe beer also. This is our wound care office that we set up. We pull up a chair. I bring down a lot of 4x4s and cling. Got donations again this year from Medline through Samaritan Hospice. They're going to donate a lot of cling and 4x4s and tape. And we take it down there. I order a bunch of creams, whatever we can use. It's inexpensive, we do. And here we go. How many people saw this last year, this slide? Okay, so be quiet. Don't say what it is. Does anybody know what that is? This would be a great board question, but it would be really nasty to put on the boards. Okay, so let's look at it. It has a little bit of a yellow inside the white border, correct? That's the hint. What is this? Nope. They have that down there, though. Got some saddle bridge nose kids, too. There's also an HIV center down there, too. I keep the students out of there. I'll go in, because occasionally they'll ask somebody to start an IV. 2 years ago, I hadn't done an IV in about 33 years, but I got it on the first stick. I was so happy with myself. What is this? Mycobacterium ulcerans. Yeah. Usually seen in Africa. People in Africa get it when they run through the brush. The mycobacterium, if you have it, stays on the brush and then it gets transferred that way. Here, these people aren't running through the brush. So they think it's being transmitted via an open wound via flies. That's the new thought down there. And it just eats away at the down to the muscle and the tendon. And it just keeps spreading. And we just try to keep it, oh, it's painless, by the way. It's treatable up here, rifampin and clindamycin. Down there, that's not going to happen. You know, I'm lucky if I have amoxicillin down there. So it's just, that's it. So it just keeps spreading. But the students get a chance to do some wound care. We have other wounds, but I just wanted to show this one. There's venous stasis ulcers down there. You know, there's pressure ulcers, so they get a chance to do all different types of wound treatment. Some suturing occasionally. So I keep them in a team to work. This gentleman saw everybody else getting a finger stick during the day. He wanted his finger stuck to get a glucose check. He doesn't have diabetes, but he just wanted to be part of the group. Like I said, they're all physically and mentally disabled. That's my wife, a neurologist, doing a finger stick. I'm not sure if I would want that done, but we let her do it. Some of the wound care supplies. And this is some of the neighborhood that we go through. They're goats. Those are drainage ditches that go through the street. They take the grills off, so at night when you drive through, you get stuck and you get robbed. Oh, yeah, so we worm our way around it. That's a restaurant that was opened by Usain Bolt called Tracks and Records. If you don't get your lunch within 9.6 minutes, it's for free. We haven't held him to that, though. That's Rami. He's an ER resident. We had some fun down there. Good guy. And there's a SWAT team in the neighborhood. I got out and asked them for a photo op. They have something, I think they're called M4s. They're not M16s because they're less accurate. Can't do that up here. We need accuracy when we're going to kill somebody. Down there, less accurate. Why? Because the neighborhood knows they're less accurate. That means if you're near a crime scene, you got a pretty good chance of getting shot too. So the crime rate has decreased since they started using these weapons. I got out and I asked for a photo op. The young lady who's sitting there, she was in charge. She came out of the building and said, "What do you want?" I said, "Just want a picture." She said, "All right, sit down." I said, "No, you sit." So as soon as she sat, I put my hands up and knelt down. They all laughed. We had a good time. They watch us go in and out of the neighborhood every day. And that's it. That's my big palliative care trip. Thank you.